Hello, my name is Kaylee Bach, and this is my presentation on asthma, specifically pediatric childhood asthma, all the ins and outs, including pre-hospital treatment and in-hospital treatment. First, let's get into what it is. So, asthma is the most common chronic illness of childhood. It's a chronic lower respiratory tract disease. Bronchospasms, mucus production, and airway inflammation lead to airway obstruction and ultimately poor gas exchange in asthma. It's an air trapping disease, meaning the problem occurs during exhalation. So inhalation might not be an issue, but exhalation becomes a big problem for asthma patients. They can't get the air out. Air trapping, inadequate ventilation, more severe hypoxemia, and hypoventilation with respiratory acidosis all will occur without treatment. Some pathophysiology for us. It's an excessive reaction from type 2 helper cells against specific allergens. These allergens I will list later. These cells, the type 2 helper cells, stimulate Ig antibodies, which release histamines, leukotrienes, and prostaglandins, which ultimately cause the bronchoconstriction. It is considered an obstructive pulmonary disease, actually, because it causes increased mucus production, making it difficult to breathe and obstructing the airway. Here I have a picture of a normal bronchiole. It's nice open, no problem breathing. Next is the asthmatic bronchiole. You can see it's very inflamed with a lot of bronchoconstriction and mucus. Some of the symptoms of asthma, we see coughing, wheezing, general signs of respiratory distress such as tripod position with their hands on their knees just trying to open their airway, intercostal retractions where their muscles are working overly hard to breathe, which is really dangerous in pediatrics because it is a sign of ultimate respiratory demise. Prolonged expiratory phase, which is a really big one for asthma because remember, it is an air trapping disease. Common triggers, told you we'd get to this. So common just respiratory infections anywhere from cold to pneumonia could cause it. Environmental allergies, you know that we have bad allergies at springtime that can cause a bad asthma attack. Cold exposure, weather changes, and secondhand smoke is a big one. If a kid grows up in a household where their parents are smoking all the time, then they're a very good candidate for asthma. Okay, pre-hospital treatment. So for mild asthma attacks, if they've already been diagnosed with asthma, we know what the issue is, and they already have a personal inhaler, and maybe they haven't used it yet, we can assist them with using their personal inhaler just to see if that helps. If it's a really bad asthma attack, we'll try albuterol. It's the most common beta-2 agonist drug used as a rescue medication treatment for mild to moderate asthma attacks. But first, before we do albuterol, we generally do a duoneb, which is a mixture of ipratropium and albuterol. Ipratropium is an anticholinergic bronchodilator. You can see all the doses here too. Dexamethasone, not as often. It's an intramuscular med, really early for severe attacks. Epinephrine is a good one. That can be given intramuscular, or it can also be given as an inhalation drug mixed with saline. It's to cause immediate relaxation of bronchial smooth muscles in order to allow the bronchodilators to work. Another option is non-invasive positive pressure ventilation. This could be CPAP in the sense of pre-hospital treatment. That can help force the air into the lungs and cause better respirations than the kid would normally be able to have. In-hospital treatment. So honestly, this looks a lot like pre-hospital treatment. Further bronchodilator treatments, further corticosteroid treatments, and ultimately, if it's bad enough, they could have hospitalization just so that they can be close to treatments so whenever they have another asthma attack or some more serious treatments. So a quick case study I thought would be good to include in this presentation. In 2020, a case study was performed on children aged 2 to 17 years treated at 7 different pediatric emergency research Canadian emergency departments for acute asthma. This was to determine whether IV magnesium sulfate had a connection to hospitalizations in pediatric asthma, whether it was good or maybe bad. A clinical trial of 816 children with severe to moderate respiratory distress was performed. In conclusion, 88.4% of children with magnesium were hospitalized, while 29% who did not receive magnesium were hospitalized. So they determined through this that magnesium did have a correlation to hospitalizations in pediatric asthma patients, and maybe it wasn't as helpful as it was once thought to be. Now, this is still a new study. Magnesium is still in a lot of our protocols as it's still being studied, but I thought this might be an interesting thought provoker in this presentation. Here are my resources. Again, this is Kaylee Bach on pediatric asthma.